have of us that they have skills that are available locally. The kinds of positions or work that's gone offshore has tended to be the commodity type of things. We're heading into an area, as we've been talking about today, where there's a demand for skills that need to be developed, and there is stimulus dollars. So for those in university programs, there's grant set up where it's a 10-to-1 matching on the first years for existing programs that are investing in education around HIT. So there will be money that can flow to the universities to build departments, to build skill sets, and that will be important opportunities for building into the higher skilled jobs that then are available locally.
You've all, I think there's unanimity on the panel about the need to create new ideas and re-engineer the healthcare system. And there's a lot of conundrums to that. I represent a venture that's going to create 350 new jobs, that's going to unclog the emergency room for hospitals, that's going to take those patients out of the hospital, create a new emergency hospital, not need state money, generate a profit, be able to handle more than twice the state requirement for Medicaid, and yet the state is putting in obstacles with the CON process and the ability to do it. So I think the problem that you have, and the gentleman from IBM raises the issue, it's a local issue, but those of us who are trying to establish new methodologies and to bring new concepts, we have re-engineered our process in an emergency room based on the technology that you guys are talking about. And it's the technology in the IT that you're discussing that has allowed us to re-engineer the emergency room process with a maximum of 30-minute wait time rather than 3.5 to 4 hours. Yet we're stymied by the local needs. How do you address that?
Well, the certificate of need law, there's a lot, and there's a lot that's changed. When we talked about, I think when Glenn mentioned the payer mix and the shortfalls, one of the things, hospitals with an emergency room, you are required by law to see everybody, stabilize and treat. And then, but if you open and say, I'm going to do all of the surgeries for the private paying patients who have insurance at my ambulatory surgery center, the law does not require you, some tweaks now under the certificate of need, physicians could see all those patients, and they did not have to take Medicaid, Medicare, anything. So they were getting, the big tension is that you have certificate of need, which is a rationing in the state of Georgia. We're one of the last states, but we're not going to get rid of it. And I hear you, but I mean, there are ways to re-engineer to some measure, but you may have the luxury of turning away people who are uninsured.
No, I will take everybody, and I want to set up the second of its kind emergency hospital in the United States. We have a model in Gilbert, Arizona, where we will unclog the system, take everybody who shows up. Our technology allows us to take anybody in. We turn away nobody. We stabilize and transfer, and we've given $45 million back to the general acute care hospitals. And I can do it without state money. I can handle all of the indigent care that comes in it, still make a profit because of the technology, but are hampered because of internal rules.
Well, and it sounds like a very interesting model, and I'd like to have further discussions with you about that. Right. But let me just say this. The reason that hospitals are very concerned about the certificate of need situation is that in addition to my little pie chart that I asked you to visualize that's 57% red, there are services that are only available at local hospitals, namely trauma. Just as one example, there are a lot of services that absolutely are draining the financial resources of hospitals. Right now, the state of Georgia pays $0 for trauma care, apart from whatever insurance you have. Okay? We are under trauma serviced, if that's a term, tremendously in the state. And trauma is an equal opportunity attacker. It attacks anybody, rich, poor, whatever ethnic background, whatever. We are not paying for trauma care in the state of Georgia, apart from whatever private insurance people have or don't have. And remember, 57% is red, so a lot of people are underpaying for that. So when alternatives come up that threaten to, we use the term cherry pick, the few profitable services that are there, we get very concerned because things like that are the only things that are keeping the doors open for a lot of hospitals. I'm not suggesting that what you're doing is doing that, but typically what happens is people are going to compete for the high-end private pay market, do things that skim off the profitable patients, and then we're left taking care of the trauma, taking care of the uninsured, that type of thing. So that's why the hospitals are very concerned about things that are what we consider inappropriately draining off the resources we need to be there to serve the community.
Question back.
Having spent the last 4 years working with the new technology, introducing this to hospitals around a specific workflow that's very well documented, it's the communication of critical values and the fact that 75% of malpractice suits are associated with miscommunication, not misdiagnosis. It's presented a real challenge from our perspective, and I'm curious to get your all's thoughts on this. The issue that we run into with the pushback, it's a very simple thing. Yeah, I want to know that my patient is sick and I want to take care of them. But at the same time, there is a lack of consistency across the direction that's provided to the hospital and to the doctor, meaning the Joint Commission is overseeing the hospital and driving their needs and wants, whether they want them or not. But that doesn't align with the doctors. And so if you look at the National Patient Safety Goals and some other things that are out there that talk very specifically around things that we want to do to improve care, they're all very realistic and very real situations, but at the same time, what you run into is because of the misalignment between what's driving the physicians and what's driving the hospitals, in the end you can't get these things installed. And so while you can at some very progressive facilities, there are also some that in the end, if a doctor threatens to take their business elsewhere where they're not using the technology because in reality they're really concerned about malpractice, which is one thing that drives everybody. It's just a question of, even if we put all this money into these new systems, what is going to align the hospital with the doctor to ensure that it's utilized correctly?
Well, just a couple of comments. First, in terms of tort reform or general civil justice reform, we need it badly, but more so every day, because if you listen to any trial lawyers, the Trial Lawyers Association are already spending millions of dollars to develop technology to drill down to EMRs to determine what doctors didn't do for the purpose of suing the doctor. It's amazing that this industry is being otherwise supported, but if we believe if you move more towards electronic systems, you can push best practices to doctors. If you push best practices to doctors and they acknowledge their presence and either document that they did or didn't choose best practice and why, we believe that creates a little bit more of a safe harbor for physicians and hospitals and others, because they can have that data right there at the point of care, as opposed to the stack of magazines that are back on their current desk right now. That if they begin to start reading what those best practices are, those emerging technologies, those emerging treatments, it's going to take them like 17 years to read through all the stuff that's just in their specialty practice. So, the tort reform issue is one that needs to be addressed. There's a great success story out of the state of Texas. If you haven't read it, you ought to read a report called the Texas Turnaround. They're adding about 4,000 physicians a year to the state of Texas because of their rather progressive tort reform efforts in that state. Oklahoma continues to refuse to adopt reasonable tort reform efforts. It's interesting. We were talking to a group in Oklahoma that says in Oklahoma we have the worst of both worlds. We're exporting all of our trial lawyers to other way around. We're exporting all of our doctors to Texas, and all of the trial lawyers are coming up from Texas into Oklahoma. So they've got the worst of both worlds.
One thing, well, there you go. You just go blank. Comparative effectiveness research is also part of the stimulus bill, which this is sort of part of the quality improvement, and the physicians and the AMA, they don't want it to turn into dictating their standards of practice because of the implications for that. But there is supposed to be now another agency, AHRQ, and they're all supposed to be developing these protocols, evidence-based guidelines, and making them disseminated. We'll see what happens. There's a big chunk of money for that, so somebody's looking for a job. Another DC.
We're going to have one more question and wrap everything up. And by the way, Jeffrey wanted me to apologize. He had to leave and catch a flight actually to go to DC. So that's what Monster.com's for. Question over here.
You folks mentioned earlier about the patient side of the equation, the end user. How does all this health IT sort of what we call trickle down to where the patient actually gets the benefit? Because at the end of the day, if the patient doesn't follow their doctor's orders, health outcomes are still crap. So can one of you guys, maybe the IBM guy, speak to that?
Well, before you hand it down, let me change the tenor of what I'm saying. This is a very positive comment. I think it's absolutely spectacular for the patient. That's what it's all about. That's why providers are in the business of taking care of patients, and evidence-based medicine, improved quality of care, improved efficiencies, not having to be repeating exams, some of which are intrusive and potentially, the very small percentage of adverse reactions from certain types of exams. So to the extent that you can reduce the exposure to that is spectacular. So 100% wonderful. That's why we need to get there.
I just want to mention about the benefit to the patient. I am a diabetic. I am chronic. So I will tell you what it will do for me personally and all the other chronic care people. I don't have to bug my doctors to give me my results. I don't have to go to the hospital to get my results. I don't have to get everything to bring to my primary care physician so he can say, do you need this test? Do I need to reorder this test? Well, I just had that test done. Those are the kinds of benefits that come when you have a connected system. Physicians want that. I can tell you that primary care physicians especially want to know when their patient's in the hospital. They don't even get that. There are docs who work in a hospital called hospitalists, and they're supposed to coordinate that. That doesn't happen. In terms of when we talked about how do you align the physician and hospital incentives, I think until this bill, it really wasn't well aligned. I think now the emphasis on connectivity and care coordination has reached, some legislative weight right now. Vendors have been trying to work together to do that, but we're also waiting on the standards. So I think the sharing of information, getting information to the patient, to the doctor, to all the players who take care of you or take care of me as a diabetic is one of the huge benefits that I'm going to see.
Before I give it to you, Sean, we also think that it'll probably engage patients. First off, it's going to improve communications. Right now, a doctor writes a prescription to a patient, gives it to the patient. That doctor has no clue if that patient takes that drug to the drugstore, whether it's dispensed, whether it's refilled. Okay? In the current system, all of that changes with electronic platforms. So there's more information that's flowing between the doctor who orders the service, the test, the prescription, and whoever's providing that. So in an electronic platform, you don't have to run around and look for that X-ray. It's in the system. Second, it's going to encourage patient engagement insofar as you have diabetes. There are certain roles and responsibilities that you as a patient with diabetes ought to do. You don't need to be leaving here and eating no Snickers bar in just a few minutes, right? Because you know what you're supposed to be doing. A lot of folks don't understand that. And we believe those electronic systems will push that communication, will create that type of patient engagement. Why didn't you take your blood pressure medication? We wrote you a prescription. You didn't get it filled. Why didn't you get it filled? And so it's going to create that kind of bidirectional communication, not only among providers, but also among patient and their providers.
Yeah, it's a great question, generate a lot of interest. We fundamentally believe that, like others here, that an engaged and active consumer of healthcare is very good for the system. When you think about it, we haven't been really engaged as consumers. We have no visibility to cost information. Typically, we don't pay for the whole thing, and we don't see all of the information that allows us to make good choices. So the more that we can engage the individual, I think the more it creates a lot of pressures, interest on the system as a whole. We've been doing a lot to invest in allowing the capabilities to make to allow and help the patient be engaged. You don't want to do the work either, and that's, I think, one of the other points is if we can make the systems talk to one another, the systems can push the information into formats in areas where it can be made available to you without it being another duplicate of paper files and manila folders that you're having to carry around on your own.
There's a provision that specifically states that if a provider has an electronic record and a patient asks for an electronic version, they get it, which is not required under the law now. So there are reasons for that a patient might want to go ahead and get an electronic copy of their record.
Well, I couldn't think of a better way to wrap it up. So I just want to thank our panel. Let's give them a hand. And of course, I want to thank all of you all for coming out and all the folks that will be watching online. And with that, I'm going to wrap it up and turn it over to
Yes, I'd like to thank our sponsors today. First, Navicure and Science. I don't think Science is here, but they were planning to be here. So just go see them at navicure.com and science.com, which is SAINCE.com. We do have Aon Consulting. I'd like to welcome Ash Merchant to talk about Aon Consulting.
Steve, thanks. Good morning, everybody. Pat, appreciate another awesome program that you guys have put on. We are delighted to be a sponsor of TAG Health. Aon Consulting is really, we're part of the larger Aon Corporation, and the three big buckets that consulting focuses on are healthcare, retirement, and human capital. You know, some of the biggest questions that we're hearing right now from our healthcare clients are swirling around: do we have the right plans in place? Do we have the right mechanisms in place to reward our employees? The last comments that were just made on the panel are very appropriate to what we're talking to our clients about. Do we have a savvy base of employees that know how to procure health care in the American healthcare system? And that's, you know, we're really helping clients right now rethink through everything, and everything as it relates to rewards, everything as it relates to health insurance. You know, what are they spending on pharmacy? What are the effects of the economy having on the perhaps mental health and productivity of our employees? So we work with mid and large size clients. We also work with small to mid size clients, and the two biggest differences are on the larger employers that are publicly traded, quarter to quarter, got to make my analyst call, I've got to make my earnings estimates, let's look at health care. Do we have the right plans in place for that? On the private equity backed side and on the privately held firms, more and more private equity firms are holding on to their portfolio companies longer, and with that, the portfolio companies are being held to a higher standard in terms of managing costs, which will ultimately affect valuations, and we're really helping companies work through how are you looking at health care, how are you looking at the utilization of your employees, how are we looking at the overall purchasing and procurement of health care. So with that, we've got a couple of representatives. Gretchen Schrader, Bob Bideman are both here representing Aon. I'm happy to answer questions as well, and appreciate being a part of the program today.
Thank you, Ash. We're glad to have you all as a gold sponsor. I'd like to also thank our media sponsor, MD News, and Sawyer.
I'll be brief, as I know you all want to get out of here. MD News Magazine goes to physicians in the metro Atlanta area. We also have another publication that the Medical Association of Atlanta has requested us to publish their journal called Atlanta Medicine, which we're very pleased to be bringing out the spring issue very shortly. We are the communication to the physicians in the metro Atlanta area, and it's great meetings like this that provide some of the content basis for our publication, and we appreciate the opportunity to be here. I'd also like to introduce Jody Isaacs, who is the associate publisher on MD News. Thank you.
Also want to mention a few other folks who have helped us in promotion of this event. The Atlanta Business Chronicle, or Urvox Caria, has done a great deal this week. WSB-TV, we're glad to see you here today. And as well as a lot of help from IBM. Their folks really helped out in PR this past week in helping us promote the event. As far as TAG Finance, who helped us out with this event, several gold sponsors there: Chamberlain Herdlicka, Accreditive Solutions, LexisNexis, and I have John Carpentier from Tarpley and Underwood.
Thank you very much. If you all figure out the healthcare system, one of visit the tax system right after that. I'm a partner in the CPA firm of Tarpley and Underwood. Two of our segments that we have a high degree of interest in and expertise in is healthcare and technology. So we're pleased to be a gold sponsor and look forward to other events like this.
Thank you. And last, I'd like to thank Georgia HFMA for being a friend of TAG sponsor for this event. We really appreciate them being involved in all of it. And lastly, sponsors are always important, but in times like this, they're ultra important. We appreciate all your support.
Clients right now.